So welcome to Practibytes.
Thank you.
Thank you for coming, Chris. So I want to introduce everybody to Chris Hopwood, Dr. Chris Hopwood, who's at University of California at Davis, right?
That's right.
A former colleague of mine, my academic brother, and a great starting point for Practibytes. So Chris, why don't you just say a couple things about yourself and then we'll talk about what we've got.
Well, it's so nice of you to have me, Megan. Always nice to reunite with family. Yeah, I'm a professor at the University of California, Davis. I study personality psychology. My background, like yours, is in clinical psychology, and a lot of my work has focused on the issue of how to diagnose personality disorders, and that has led to other questions like how to treat them, are they treatable, how stable are they, and that sort of thing.
Yes. So what do therapists need to know about diagnostic assessment of personality and personality disorders?
Uh-huh. Well, in the DSM-3, as clinicians know, there was a big change in the DSM, and one of the changes was the introduction of a separate axis with personality disorders. And at that time, the idea was every patient has symptoms, but every patient also has a personality, and the symptoms should be understood and conceptualized and treated within the context of who the person is. We had 20 or 30 years to study that model, and it turns out there was a bunch of problems that made that difficult for clinicians. Like it was common for two people to have the same diagnosis, or two people with the same diagnosis would have different kinds of presenting problems. And so it didn't really lead to a transformation in mental health. And in fact, it created the impression that personality disorders are untreatable, which doesn't turn out to be the case. And so by the time the DSM-5 came along, the idea was, okay, we need to fix this. And the alternative model of personality disorders was an effort by the DSM Personality Disorders Work Group to fix it. And what they did was they removed the categories from the DSM-3 and 4, and they replaced them with a dimensional model that has two parts. The first part is, how many problems overall does the person have? And if the person has a sufficient amount of problems, then they're eligible for a personality disorder diagnosis. And the second part, criterion B, is what kind of problems does the person have? And that part is based on a trait system rather than a disorder system. And one of the nice things about it is that this trait system resembles really closely the way scientists think about personality. And so you can draw upon the general scientific literature about how personality works to inform diagnostic practice. The next steps, of course, are to figure out, well, how do you use this alternative model for psychotherapy planning? Because what we know is there's now a bunch of treatments that seem to be fairly well validated for personality disorders. So that sort of myth that personality disorders don't change, that once a person has one, they'll have one for life, doesn't turn out to be true. We know that there's several treatments, particularly for borderline personality disorder, but the connections between those treatments and this alternative model haven't yet been fully articulated.
Awesome. So what's the deal with the categories? What's so bad about the categories?
Yeah. Well, there's a couple of issues. One of them is that you lose information. So if I were to say to you, there's three kinds of people: short people, tall people, and middle people, and then you were to say to me, well, I'm 5'7", you'd probably be on the border as a woman between, say, medium and tall, right? And that would, if you were put in the tall group, that would make you just like a woman who's 6'4", which would lose a lot of information. So one thing is we just need to have a full range so you can say, well, how severe is this person's personality problems, rather than do they have a personality or not? The second issue is that the way that they go together doesn't turn out to be valid. So it's not the case that there's 10 different kinds of personality. Rather, it's the case.
What do you mean? What do you mean there's not 10 different?
Yeah, in the DSM, there's 10 personality disorder diagnoses or a no personality disorder diagnosis. The implication being you have to fit into either one of these 10 personalities, or your personality isn't important for understanding you. And that's just not the way that people tend to think about other people, or the way nature sort of works. Instead, everybody has a personality, whether they have a diagnosis or not. And there's a few basic traits that can be used to distinguish one person from the next in terms of their personality.
Do the traits actually do anything valuable? Like when you just look at normal traits, what do they bring?
Yeah, well, one thing we know is that traits from a very early age can be used to predict all kinds of important long term outcomes, like how much money people will make, how long they'll live, whether they'll have heart disease, how happy they'll be in their marriage, and all that sort of stuff. So that's where I was mentioning earlier about connecting diagnosis to the basic literature on personality has some value. We know about the heritability and the course and that kinds of things of these traits.
So where are we now with DSM-5? Like, what is the model, and does it make sense? Like, is it working?
We know that professionals and scientists tend to prefer the alternative model to the categorical model. However, the APA still uses the categorical model in its official section, and the alternative model is called an alternative because it's sort of a different option that one can use. I think that the good money is on the alternative model ultimately replacing the categorical model. And actually, that applies not only to personality disorders, but probably to the entire scheme, because all the problems I mentioned with personality disorder categories also apply to psychopathology in general.
Wow, what you're saying sounds very revolutionary.
There's a consortium called HiTalk, which are a group of psychiatrists and psychologists who are all trying to push this kind of idea forward so that diagnostic practice, i.e., the DSM, can be better connected to clinical practice.
That's awesome. And what's the takeaway for therapists then? Like, if they use the alternative model, will that help their work?
I think the kind of irony here is that the alternative model and dimensional models in general probably are closer to the way clinicians already think about their patients anyway. So in some ways, it's not so much a new thing for clinicians to learn or get a grip with. It's more like this is something that might get the DSM closer to the way we already think about other people and our practice and conceptualization.
Yeah, that's totally true. Because I know if I think about the people that I see, I don't think about their personality disorder. I think about like they're introverted and how is that affecting their life, or they're neurotic or whatever. I'm not really thinking about their criteria.
That's right. And if you're a psychologist trained to use tests like the MMPI or the PAI, the kind of thinking in the alternative model will be super familiar. It's very similar to that way of thinking.
Wow, that is great. Okay, thank you so much for teaching us about diagnostic assessment.
You're welcome. Thanks for having me.
My pleasure.